So, g'day, I'm Dr. Paul Mason, and today I'm going to talk about something which represents an existential threat to many contact sports: concussion. Specifically, I'm going to submit a paradigm which I believe will inform both future research and treatments for concussion. In this historic paper, John Martland described a peculiar condition which even in 1928 had been recognised for a long period of time, that of punch-drunk syndrome. The visible symptoms of punch-drunk syndrome have been long known to fans and promoters of boxing, various phrases being used historically to describe fighters in the early throes of this condition. Martland describes how fighters would be described as cuckoo or goofy, or perhaps even more apt, slug nutty. They were, of course, referring to what we now call chronic traumatic encephalitis, or CTE. And CTE is a neurodegenerative disease linked to repeated head trauma. Now, there is still some debate as to whether concussion is a cause of CTE. Indeed, the recent 6th consensus statement on concussion describes a spectrum of perspectives, no doubt code for there being serious disagreements between members of their expert panel. Ultimately, I think that the view that concussion can play a causal role in the development of CTE will win out, and the evidence in my eyes being quite compelling. Regardless, concussion clearly represents an existential threat to many contact sports, while also presenting undeniable medico-legal risk to health professionals. Some rugby schools here in Australia even have parents sign an acknowledgement of the risks of concussion long term. And the path of healthcare professionals is far from clear. This recent consensus statement specified that the advice contained within should not be considered a legal standard of care. And so on that basis, clinicians are caught in the middle, responsible for the care of concussed athletes with no reliable guidance as to how to actually treat them that will stand up in a court of law. The fact is, even in 2023, treatment options for concussion remain limited and arguably relatively ineffective. Of course, that's not to say there hasn't been some progress. Smelling salts, for example, were once commonplace in the treatment of a dazed athlete. Just in the intermission, I was chatting to somebody who was previously involved in the administration of smelling salts to NRL footballers up until the early 2000s. And even now, we're still seeing smelling salts make an occasional appearance. In this 2020 boxing match, the Russian boxer on the right, after taking several blows to the head, returned to his corner at the completion of the 7th round. His trainer, after applying some Vaseline, then waves smelling salts under his nose, and you can see he visibly recoils from this, a predictable response to the inhalation of ammonia. He subsequently returned to the fight and won by KO. But smelling salts aside, until fairly recently, the mainstay of concussion treatment was rest, both physical and cognitive. And it's now recognised that strict rest is often counterproductive, and this meta-analysis found that light physical activity in the first 2 days after concussion and prescribed aerobic exercise between days 2 to 14 can actually facilitate recovery. So neither absolute physical nor cognitive rest should be prescribed. Having said that, I must make it abundantly clear that continuing to play does not count as light nor therapeutic exercise. It's clear that continuing to participate in sport while concussed does delay recovery. Vestibular rehabilitation is also receiving increased attention as a possible means of accelerating recovery from concussion. And this recent systematic review concluded that visual interventions and cervical manual therapy reduced the time to return to sport. Whether or not this actually represents an accelerated recovery from concussion, though, remains to be seen. It's possible that these athletes receiving this intense intervention are simply progressed more rapidly through the stages of rehabilitation. Another element is what we call subsymptom threshold aerobic training, and there is some research evidence that if symptoms have persisted for more than 4 weeks, this may offer some benefit. The fact is, though, for all intents and purposes, conventional management of concussion is limited in both its scope and its efficacy. In effect, the basis of concussion management could be described as watchful waiting, during which the athlete is guided through a series of progressions in terms of their cognitive and physical activities. And one of the major reasons why treatments are so limited is a poor understanding of the underlying pathophysiology of this condition. First of all, for reasons beyond my understanding, there is still debate as to whether concussion represents a structural injury. The recently published 6th Consensus Statement on Concussion, for example, allows only for the possibility of axonal injury. And I think the evidence of structural damage is compelling. One study in 1994, for example, autopsied the brains of 5 individuals who had recently suffered concussive injuries but then died from other causes. And all 5 were found to have structural axon damage. And of course, there's been much more extensive research over the last 20 years to add to this. For example, blood biomarkers are currently being extensively investigated. So many tissues contain certain molecules that are relatively specific to that tissue. And damage to that tissue then can release these molecules into the bloodstream. So high blood levels of something called creatine kinase, for example, is highly suggestive of muscle injury. And it's also the case that there's certain molecules which, when we detect them in the circulation, indicate likely neuronal injury. One example is glial fibrillary acidic protein found in brain astroglial cells, or UHCL1, from the cell bodies of neurons. These have both been approved, in fact, by the FDA to identify patients who require a CT scan after head injury. Both rise after concussive injury and are still detectable at 7 days. So putting aside the question of structural damage for now, concussion also results in what is loosely termed functional impairment. In effect, regions of the brain cease to function normally. This is evidenced by an overall drop in glucose metabolism by neurons after concussion, which predictably then impacts on the function of those very neurons. This graphic, for example, shows the difference in glucose metabolism between military personnel who acquired a mild traumatic brain injury consistent with concussion and aged matched controls. Likewise, this graph from a study of boxers demonstrates clear impairment of glucose metabolism in various regions of the brain. And this impaired ability to utilise glucose results in what has been for a long time called an energy crisis. And the mechanism for this is something called insulin resistance. You see, neurons without insulin receptors have membrane protein transporters called GLUT3 transporters in their membranes, which allows for the entry of glucose into these cells. Other neurons, however, typically clustered in specific regions of the brain, rely on activation of an insulin receptor, which you can see here spanning a cell membrane, in order to take up glucose. So when insulin binds with an insulin receptor, a signalling pathway within the cell is activated, which ultimately results in the insertion of a different transporter, a GLUT4 glucose transporter, into the cell membrane. And this then allows glucose to enter the cell. And in those neurons which are dependent on the activation of insulin to take up glucose, any impairment of the function of the insulin receptor can render the neuron unable to take up glucose. And the function of insulin receptors can and is impaired by concussive trauma. You see, insulin receptors are embedded in special regions of the plasma membrane, which is very rich in cholesterol, and this is called a lipid raft. And concussive impacts can physically damage the attachment of the insulin receptors to the surrounding lipid raft. And this has been shown in experiments where mice have been concussed by dropping weights onto their heads. And disruption of the lipid raft and insulin receptor function has been conclusively demonstrated. And in humans, insulin resistance has clearly been associated with poorer outcomes following head injuries, though not yet shown for concussion alone. But the findings in mice of this concussion-induced insulin resistance also correlates closely with another serum biomarker we see in humans, something called plasma-soluble prion protein. And the importance of plasma-soluble prion protein as a biomarker lies in its ability to tie together the concussive mechanism of insulin resistance. You see, this is closely associated not only with the lipid raft in cell membranes, but also insulin receptors themselves. And following a concussive impact, this protein can be dislodged from its attachment to the lipid raft and released into the circulation. So this study recruited athletes between the ages of 18 and 30 and measured their baseline levels. Subsequently, 6 of these athletes suffered a concussion, and you can see that 1 to 7 days later, there was a near doubling of this biomarker, compelling evidence that the mechanism for insulin resistance, as seen in mice, also applies in humans. Now, you'll remember that concussion doesn't affect all regions of the brain equally. So neurons in particular areas of the brain appear to be particularly susceptible, and this appears to relate to the density of insulin receptors in those neurons, and this makes sense. Here you can see insulin receptors stained in green, densely populating the hippocampus, a region of the brain central to memory, and also vulnerable to concussive injury. And this is something that we've known for a long time. And the thing is, these concussive impacts on the hippocampus don't simply relate to glucose metabolism, it also appears that there's long-term structural consequences, as evidenced by the hippocampal shrinking or atrophy, which has been found even in young athletes with a history of concussion. And this makes sense, however, as the energy crisis that results from concussion, effectively starving neurons of energy in the form of glucose, triggers a biochemical cascade that undoubtedly ends in neuronal injury. So it's precipitated by a failure of energy-hungry ion pumps, which then eventually leads to the development of neuronal swelling and subsequently axonal damage. There is one intriguing possibility that might allow us to avoid this energy crisis though, and that's supplying an alternative fuel source that doesn't require the action of insulin, namely ketones. You see, ketones represent a group of compounds that can be produced from acetyl-CoA that results from fatty acid metabolism, and they can provide a significant amount of energy to the brain which does not require the action of insulin. In other words, in a concussed state, ketones will still be able to provide energy to the brain. Whenever the availability of ketones in the circulation increases, the use of ketones by the brain also increases. In fact, there's almost a linear relationship. And even more importantly, when we increase circulating ketone levels, we reduce the use of glucose by the brain. Ketones, in fact, are a preferred fuel source. The problem is there's basically no research looking at ketones and concussion. We only have this small pilot study which wasn't even performed in the acute concussive period, but rather on subjects with prolonged post-concussion syndrome. And while it did find some benefit in visual memory, it's far from complete evidence. With this in mind, understand that insulin resistance is widespread among many other neurological disorders, including Alzheimer's and Parkinson's diseases, schizophrenia, and major depression. And there's increasing research proving the benefit of ketones in the management of these conditions. So given the research on ketones and concussion is lacking, I'll present some studies looking at the potential benefits of ketones in these other neurological conditions known to be associated with insulin resistance. So research on the brains of patients with Alzheimer's disease clearly demonstrated improved metabolism when provided with ketones. See the increased metabolic rate between the left and the right when the brains of Alzheimer's patients are fed with ketones? And of course, a ketogenic diet can achieve the same result. In this study, 4 days of a ketogenic diet resulted in ketones providing 33% of total brain energy. And this is another study which compared the rates of brain metabolism in those at risk of Alzheimer's disease. And you can see a massive improvement in brain metabolism on a ketogenic diet. There are some problems, however, with the use of ketogenic diets in concussion. And one of the major ones is that it takes some time for the level of ketones to build up after commencement of a ketogenic diet. And given that the structural downstream consequences of metabolic dysfunction can occur within hours, starting a ketogenic diet after a concussion is akin to shutting the gate after the horse has already bolted. Rather, athletes already on ketogenic diets before a concussive episode are much more likely to see benefit. The fact is there needs to be a lot more research in this area before we can draw firm conclusions. Now, oxidative stress also appears to play a significant role in the biochemical cascade that results in structural damage after the onset of metabolic dysfunction. And this raises the question of whether antioxidant supplements may also have a role. And the answer appears to be yes, at least in the case of N-acetylcysteine, a potent antioxidant. This study was a randomised, double-blinded control trial of US military personnel who suffered mild head injuries after exposure to explosions, and subjects were given either a placebo or N-acetylcysteine. And this graph records the mean number of symptoms suffered, including headache, memory loss, sleep disturbance, and dizziness. And in red, you can see the subjects who got the N-acetylcysteine clearly had a much less reduction in their symptoms than the subjects who received the NAC in blue. Compare the entry columns to the day 7 columns. Once you add NAC or NAC to the equation, concussion symptoms get much better, much more rapidly. And given it's a very safe supplement with a long history of use, I think it's worthy of consideration in the early treatment of concussion. Now let's get back to the problem of an energy crisis. And many of you are probably familiar with creatine, which is a compound that's able to donate its phosphate group to ADP to form ATP, which is the currency of energy in the body. And not only is creatine found in muscles, but also the brain. And it's known that creatine levels in the brain fall after a concussion, which is why there's been some research on the use of creatine after traumatic brain injury. So this paper was a small-scale randomised controlled trial that compared supplementation of high-dose creatine for 6 months against a placebo in head-injured patients. And the results were striking. Check out the reduction in headaches compared to controls, in dizziness, and fatigue. Highly significant results that are very promising. And this, unfortunately, is the only significant human trial of creatine in brain trauma, although several animal studies have also indicated a likely benefit. Again, however, as with NAC, given the excellent safety profile, judicious use in concussed patients could certainly be considered. I'd like to now discuss another source of structural injury and concussion. The pituitary gland is buried deep in the brain and it releases several important hormones. It sits at the end of a flexible stalk called the infundibulum. And being ensconced within a bony chamber, the freedom of movement which this attachment to the stalk permits makes it vulnerable to structural injury following concussion. And this is why repetitive head impacts and traumatic brain injury are known to result in disturbance to the anterior pituitary gland, and we call this post-traumatic hypopituitarism. And this shouldn't be a surprise to anybody. The fact is, the first article describing this phenomenon was described more than 100 years ago in 1918. What might surprise people, though, is the extent of problems which can arise from this dysfunction. You see, the pituitary secretes 8 major hormones, and post-traumatic hypopituitarism has the potential to impact them all. And it results in an array of disorders ranging from low growth hormone, low thyroid hormone, impaired cortisol deficiency, right through to disturbances of sex hormones or a condition called diabetes insipidus. and have no doubt that sport-related concussion can induce post-traumatic hypopituitarism. This study on retired boxers found that 47% of them had a growth hormone deficiency, something very unlikely to occur by chance. This study identified hormone deficiencies in 23.5% of retired NFL footballers. And cases have also been reported in soccer and swimming. The fact is, post-traumatic hypopituitarism is frequently overlooked as a source of chronic symptoms in athletes, and it's something which we as clinicians should specifically seek out. Now, my last topic is... Okay, I think that's the end of my talk. I don't think we'll get through. We might get through it. While headaches are a very common symptom of concussion, there's a particular type of headache we should look out for. It's well known that traumatic head injuries can result in disruption of the dural membrane surrounding the brain or spinal cord, and this can result in leaking of the cerebrospinal fluid and lead to a characteristic severe postural headache, which improves almost immediately on lying flat. And this can occasionally be seen in a concussed athlete, and the most likely cause of this post-head trauma is disruption of the dura around the spinal cord, not the brain. Usually between C5 and T7, it relates to the presence of small spinal osteophytes which are able to pierce the dura, and in my mind this likely associates with the whiplash mechanism that we often see associated with concussion. And the significance of identifying this type of headache, which while uncommon, is that it can be treated with a blood patch. When blood is injected into the epidural space, up to 87% of the time, this condition will be successfully treated. And so, in closing, there is, I believe, sufficient evidence that head impacts can result in structural disturbances, one of the consequences of which is insulin resistance. And if we understand the consequences of insulin resistance, then that gives us information that potentially antioxidants, creatine, or ketones might be useful therapeutic strategies. And this may guide us to a future where the mainstay of the treatment of concussion is no longer wrapping athletes in cotton wool. Thanks for listening.